This recording will cover pneumonia. So first we'll start with what's the problem with pneumonia? Pneumonia is when excess fluid accumulates in the lungs from an inflammatory process. And this excess fluid, you can imagine, causes a reduction in gas exchange. The inflammation is triggered by infectious organisms and by inhaling irritating agents. So it's not always an infection. It can be a non-infectious irritant that causes pneumonia also. Organisms then invade the airway and alveoli with infection. The white blood cells migrate to the infection, or there's inflammation with an irritating agent that causes local capillary leak, edema, and exudate. Fluid collects in the alveoli and alveolar walls thicken. So think about what the alveoli do. That is where gas exchange occurs. And if you have fluid collecting in the alveoli instead of gas, that obviously is going to lead to a reduction in gas exchange. The end result would be hypoxemia. Red blood cells and fibrin move into the alveoli, and capillary leak spreads the infection to other areas of the lung. Two terms you should be familiar with are septicemia, which occurs when the infectious organism spreads to the bloodstream, and empyema, which is an infection in the pleural cavity. The fibrin and edema end up stiffening the lungs, which leads to reduced compliance or movement elasticity and a decreased vital capacity. So less oxygen and air can be held in the lungs. Atelectasis, remember that term, is when the alveolar collapse, also leads to reduced gas exchange and hypoxemia. A term you may hear is consolidation, maybe when you're looking at x-ray results or in report in the clinical setting, and that stands for or signifies solidification or lack of airspace. So if you have an x-ray report that notes consolidation in the lung, that's a bad thing because that means where air should be, it's not. Something solid is in that space, like fluid. I shouldn't say solid, but something other than air is in that space. Like we've already said, pneumonia can be caused by an infection, whether it's bacterial or viral, fungus, or also non-infectious agents such as toxic gases, chemical fumes, smoke, and importantly, the aspiration of water, food, fluid, or emesis. That's why we're so cautious with our patients who are at risk for aspiration because we don't want them to develop pneumonia. Pneumonia can be classified as community-acquired pneumonia, healthcare-acquired pneumonia, hospital-acquired pneumonia, and ventilator-associated pneumonia. And those terms you should be familiar with. We're going to look at the hospital-acquired one here for a second. Hospital-acquired pneumonia, the onset or diagnosis of pneumonia is greater than 48 hours after admission to the hospital. That would be classified as hospital-acquired. And it's important for us as nurses to know what to do to prevent the patient from developing pneumonia while hospitalized. We need to encourage pulmonary hygiene and progressive ambulation. So what's pulmonary hygiene? Sort of a weird term, but that's the incentive spirometer, the coughing and deep breathing, the things that are keeping our lungs healthy. Ambulation is important. Make sure we're telling the patient why we want them to get up and walk. They're feeling sick. They don't want to walk. They think we're just there torturing them, and they need to know about the risk for pneumonia, and that's why we're getting up and walking. Provide adequate hydration. Assess risk for aspiration. Monitor for early signs of sepsis. Hand hygiene is critical, and provide vigorous oral care, especially for our patients who have a decreased level of consciousness. You might want to delegate to the aide, but follow up because good oral hygiene can prevent pneumonia. Those identified to be at increased risk for pneumonia include the older adult, the patient with a history of respiratory problems, the patient with limited mobility or the patient confined to a chair or bed, person with altered level of consciousness, at risk for aspiration, or the patient who has any sort of tubes, NG tubes, ET tubes, or the patient on a vent. When assessing your patient's history or asking about the history, you want to find out if they have any risk factors for pneumonia, any aspiration risk factors, Do they use tobacco or alcohol? Any past respiratory illnesses? Are they taking adequate care of any respiratory equipment they're using? Are their vaccinations up to date? Has there been any change in cognition? In terms of signs and symptoms for the patient with pneumonia, we'll see an increased respiratory rate and heart rate. And that usually is associated with hypoxemia, right? There's less oxygen in the blood, so the patient starts breathing faster, trying to get more oxygen, and the heart rate increases, trying to get oxygen out to the body. Could also be related to, an increased heart rate could also be related to dehydration if the patient has some dehydration. Other signs and symptoms: hypotensive due to vasodilation and dehydration, especially in the older adult. A rapid, weak pulse. That could be from the hypoxemia, dehydration, or an important clue of impending sepsis and shock. So if you have a patient that starts having a rapid, weak pulse and their blood pressure is dropping, we'd be concerned about sepsis and shock. Fever and chills, dyspnea. Patient may be uncomfortable lying down and positioning themselves in the tripod position. Hypoxemia, sputum, could be purulent, blood tinged or rust colored. Pleuritic chest pain, chest muscle weakness from coughing. Adventitious breath sounds will include crackles, sometimes wheezing. Breath sounds may be diminished. Fremitus will increase, chest expansion diminished or unequal. Dysrhythmias can occur due to cardiac tissue hypoxia. Always remember that signs and symptoms of infection in an older adult are usually atypical, so they might not have the big fever and the white blood cell count that's through the roof. Most common symptom for infection in an older adult is change in cognition, with acute confusion from hypoxia in the case of pneumonia. So you want to watch for a change in cognition, confusion. Again, the older adult may not have a fever and the white blood cell count may not be elevated. Another sign and symptom the patient may experience is anxiety. It could be because of the low oxygen and not feeling well, being scary. We want to make sure that we listen, we have a calm approach. And if the patient is dyspneic and has problems with breathing, we want to make sure that we limit any discussion. Don't ask them to tell you their life story all in one breath. Complications from pneumonia include septicemia. That's when the infection has moved to the bloodstream. So that's obviously a very bad thing when infection that has been kind of local, whether it be in the lungs or a bladder infection, moves into the bloodstream. Then you have the infection traveling throughout the entire body. Very bad. Sepsis is a very serious complication. Empyema, which we'll talk about in a little bit, and ARDS, acute respiratory distress syndrome, which we'll talk about in an upcoming lecture. So what labs are we going to look at for the patient with pneumonia? Obviously, the best information to get about the patient's oxygenation comes from the ABGs. A sputum sample, remember a CNS stands for culture and sensitivity. So you get a sputum sample, you do the culture, which shows you what organism is growing, and then the sensitivity tells you what medication can treat that organism. Blood cultures. So why do you think we're doing blood cultures? We're looking for septicemia, see if the patient is septic. Usually blood cultures are drawn for 2 separate spots on the patient. White blood cell count. We want to see if the white blood cell count is elevated. Which patient would normally not, or I don't want to say normally because sometimes they are elevated. Which population might not have elevated white blood cell counts with an infection? Your older adult, right? As with everything, the older adult, stuff quits working as well. In this case, the immune system. So those white blood cells don't peak like they do in a healthy younger adult. BUN and serum creatinine. Those are our 2 labs that are watching kidney function. You should be familiar with the normal values for those 2 labs. Especially BUN gives us information about dehydration also. Electrolytes. Hypernatremia can be seen in the patient with dehydration. Dehydration can be common with the patient with that increased respiratory rate. Can be one of the factors that leads to dehydration in the patient with pneumonia. Lactate levels will give us information about sepsis. So if they're elevated, and usually in the clinical setting, you'll see the millimoles, so the 0.3 to 0.8 being a normal. Chest x-rays, the most common. Very important for our older adults to have that chest x-ray as a diagnostic because their symptoms are so vague, it's sort of hard to pinpoint what's going on. Pulse oximetry, continuous pulse oximetry may be on your patient to continuously monitor that SpO2. And finally, thoracentesis if the patient has a pleural effusion. A pleural effusion is a collection of exudate or fluid in the pleural cavity, and a thoracentesis is a procedure in which the fluid that's accumulating in the pleural cavity is drained.